I'm Dr. Maad Al-Amr. This 56 years old male presented in the clinic after failed conservative treatment, complaining of pain at night and with overhead activity. MRI was done, showed supraspinatus and slap tear. Diagnostic shoulder scope was done, and the finding for a slap tear was noticed. So a biceps tenotomy was done because of the patient's age and low activity, debridement of the soft tissue and the tear site, and the rotator interval was done. Subscapularis was evaluated and found to be intact. Then our attention was shifted towards the supraspinatus footprint, and as you can see, a complete tear is seen. Now the camera position is changed into the subacromial space, viewing from posteriorly, and debridement and bursectomy is done using a shaver and a coablator to increase the space for better visualization. Two portals are made, one anterior and the other one is anterior lateral, and the camera position will be changed from a posterior position to a lateral position. Debridement of the supraspinatus footprint and preparation for later repair and anchor placement will be made. Now we are assessing how many anchors we need and the position of each anchor using an owl or a punch to create a pilot hole, and an owl suture anchor is being inserted, double loaded. The first posterior anchor is loaded, and then the second anchor is being inserted. A suture retriever is being used to pull each suture, and an anti-grade suture passer is used here to pass the suture through the tendon for later tying. The same process will be done for the rest 8 sutures to pass them through the tendon and tie them later. Each 2 sutures are pulled outside the shoulder joint, and a knot is slided inside and tied. Due to the size of the tear, an added fixation decision was made, and all the sutures are pulled through a knotless anchor, which is fixed laterally in a double row fashion. By that, the complete repair is done, and the patient will be placed in an arm sling, starting early passive range of motion and pendulum exercises.